well.
So thank you everyone for joining today. I'm very excited to introduce you to Professor Miranda Lomer. She is a senior consultant dietitian at Guy's and St. Thomas hospitals in London, and has an adjunct appointment as a professor of dietetics in gastroenterology at King's College London. Professor Lomer is first qualified as a dietitian in 1990, and in 2002 she completed a PhD on diet and Crohn's disease. Her research interests include the nutritional management of functional bowel disorders like esophageal reflux disease and IBS, as well as inflammatory bowel disease, including Crohn's disease and ulcerative colitis. She has research skills in dietary assessment and nutritional management of these conditions, and has expertise in conducting national audits, developing national guidelines, and conducting multi-center trials. She was the chair of the Gastroenterology Specialist Group of the British Dietetics Association from 2006 to 2010, and represented that association on the National IBD Standards Group Steering Committee from 2007 to 2012. She was also a committee member of the Dietitians of the European Crohn's and Colitis Organization, and she was on the Medical Research Awards panel for the Crohn's and Colitis UK between 2017 and 2023. She's been a GUTS UK trustee committee member since 2019. She's also the editor of a book in advanced nutrition and dietetics for gastroenterology. And she gave the Dietetics Association Widowson Lecture in 2014 as a recognition of her international impacts in this field. So today she will share her talk with us entitled Impacts of Dietitians Working with IBD, and I will let her take the center stage now.
Thank you very much, Anna, for your kind introduction and for welcoming me to Chapel Hill. This is very exciting. This is a view from St. Thomas's Hospital looking over to the Houses of Parliament. So we do have a most amazing view straight from the hospital. And I've been working at Guy's and St. Thomas's since the early 90s. So I've been around for quite some time in this area. So I'm going to be talking about the British Dietetics Association, or the BDA, consensus guidelines on diet and inflammatory bowel disease, and specifically focusing on nutrition assessment and screening tools in inflammatory bowel disease. Looking at some of the work, I'm particularly interested in using exclusive enteral nutrition to induce disease remission, and also pre-surgical nutritional optimization of Crohn's disease, and also diet and the management of functional gut symptoms in IBD. So we started work on developing the British Dietetics Association consensus guidelines on nutrition assessment and dietary management in IBD before the pandemic, in fact, and decided that these consensus guidelines were really needed because the quality of evidence for diet in inflammatory bowel disease is very low, and to actually get wide approval of guidelines, they really need to be driven by consensus. So we invited experts from the inflammatory bowel disease community, including healthcare professionals and patients with IBD. And by the end of the voting periods, we had 55 participants who completed 3 rounds of voting. And during that period, we had 14 grade statements and 42 practice statements agreed with, i.e. they reached 80% consensus. And these are really going to be something that I refer back to throughout the talk. So I just wanted to highlight what they were and where they came from. In terms of inflammatory bowel disease, malnutrition is highly prevalent. However, when you look at prevalence, it ranges hugely from sort of 6 to 85%. And that really depends on the assessment criteria. So whether you're dealing with Crohn's disease or ulcerative colitis, whether you're dealing with active disease or patients in remission, and also depending on the phenotype as well, whether it's fistulizing or stricturing, and all of these will impact the prevalence of malnutrition in IBD. When we look at nutritional assessment, we have a whole range of tools that we can be using, and the most common is weight, but we do need to be thinking about weight and BMI alongside other tools as well. So things like muscle strength and function and body composition, and trying to get patients to take ownership of their own nutritional assessment as well by getting them to self-assess themselves. A few years ago, I did some work with a few colleagues from ECHO, Kostas Gerasimidis from Glasgow, and two colleagues from Greece. And we looked at measuring nutritional screening in a IBD patient population. And we found that BMI is really not a very good predictor of muscle mass. Many of the patients that we assessed were, according to BMI, were very obese or overweight. Most were in the normal range, and only a few were actually underweight. Now, when I started working in inflammatory bowel disease, we used to see so many more patients who were underweight, and since the obesity pandemic, then it's really come to the forefront that we have this issue around using BMI as a tool in isolation in IBD. So in the BDA guidelines, we've looked at all the different tools to measure different aspects of anthropometrics, including body composition, and have identified that we really need to be thinking about just going to move this over. There we go. We need to be thinking about disease activity being affected by body composition in inflammatory bowel disease. And it's really important to assess nutritional status longitudinally over time using body mass index in combination with other assessments of body composition and or muscle function. And this particular practice statement got 96% agreement. What we also know is that we need to be aware of systemic inflammation and how it affects body composition, often with a reduction in muscle mass. And so we really need to be aware of that in patients, particularly those who are overweight, and sarcopenia is really common. And relying on weight and BMI only can mask changes in body composition. So it's really important that we use these other assessment tools. However, in clinical practice, a few years ago, we looked at what nutritional assessment tools were actually being used in clinical practice. And if you look at the dedicated number of dietetic sessions for gastroenterology, this is less than 5 per week. So this is equivalent to a dietitian working 2.5 days per week in a clinical setting in gastroenterology. And more than 5 sessions per week would be anywhere from sort of half a dietitian to 1 or more dietitians per week. And what you can see here is that the more tools that were actually being assessed is where you have more than half a dietitian per week dedicated to gastroenterology. So that goes without saying that if you've sort of got the ability to measure all these things because you've got more dietetic time, that's really important. And in the UK, this is one of the things that I've really been trying to promote in the last sort of 15 years or so, is to try and get more dietitians working in gastroenterology, and particularly in inflammatory bowel disease. We produced this narrative review with one of my colleagues, Alicia Sandel, and we really wanted to make sure that in inflammatory bowel disease, all these assessment tools are being used appropriately and effectively, and there are easy ways that we can actually see what the reference ranges are, what methods need to be used, and what measures might be undertaken. So, for example, in the anthropometric section at the top here, We've got hand grip strength, mid-upper arm circumference, trifect skin fold thickness, mid-upper arm muscle circumference, bioelectrical impedance, and novel imaging methods such as CTs and MRIs, and some methods that might be useful, and then the reference ranges that would be used. And then in the middle here, the figures are just expanded on these slides, just to give you an idea of what you should be doing to actually measure these things so that you have got good repeatability. And again, for hand grip strength as well. So these things are really important. And this particular page that I've just shown here is on a big A3 sheet. So if you manage to find this publication, you can always print it off and put it on your wall for clinical practice. From this, in terms of nutritional assessment, we wanted to develop and validate a nutrition self-screening tool for IBD. And the reason for this is in the UK, we often use the MUST tool, which is not IBD specific. And some of the questions in there really can be a little bit ambiguous. So when we went through the process of developing this tool, we went through an initial step developing the content with an IBD expert panel. And then we went through the 3 different phases. So phase 2 was where we looked at the face validity of the tool and the content validity by repeatedly going back and assessing the tool and observing how patients were finding it in terms of completing it and answering questions. And then we looked at convergent validity to look at all the different questions we'd put in and measured the repeat reliability once we had finalized the tool and created a digital version of it. The final tool looks like this, where you calculate your body mass index to start with, and then you score different points depending on what the result is, and then calculate an unplanned weight loss score. And then the next question is, are you having any flare of your symptoms? And do you have any food and nutrition concerns? If the patient says yes to both of these questions, then they would score 2 points. Otherwise, they would score 0. And the whole reason for having this section in here and this question on, do you have any food and nutrition concerns, is because we're trying to identify patients who might need to see a dietitian, but they may not be overtly malnourished as such. So it's really trying to capture those patients that are at nutrition risk, as opposed to those that are at risk of malnutrition. So it's really trying to capture before things get really bad for some of these patients. And then step 4 is adding the scores together and coming up with a score to identify what the risk might be. Patients at moderate or high risk can be referred to a dietitian if they speak to their IBD team. In terms of the repeat reliability, we did this in a digital version of the tool and looked at 2 records of using the tool over a week in between each method, each recording, and found that there was really good agreement in terms of weight and height that was entered correctly, with 95% agreement, and the IBD NST score had substantial agreement at 85% between the 2 recordings, 1 week apart. So this was really good, and you know, we're now encouraging people to be using this tool in clinical practice. We do have it built into our electronic patient record at the moment, but we don't have any data as yet in terms of how it's being used. But I would say from a guideline perspective, it's really important that nutrition screening is considered an integral part of the IBD care pathway in the IBD multidisciplinary care setting. And what we're talking about here is nutritional risk, not just risk of malnutrition. And it's important to note underneath here that body mass index is not an accurate marker of malnutrition in IBD patients, and reduced lean body mass may be missed in patients with a normal or high BMI. So in addition, dietary exclusion to manage symptoms is common, And this is why we put the question in there about food and nutrition concerns, to make sure that we were capturing this within our tool. So let's move on to some of the dietary management strategies that that I'm particularly interested in. So exclusive enteral nutrition to induce disease remission is going to be what we first look at. So exclusive enteral nutrition has been around for a long time, as I'm sure many of you know, and an elemental diet was first used back in the 1970s. It was actually used by astronauts going into space to try and reduce the residue in their stool output. It was then considered that this kind of treatment might be useful to be used as a primary or adjunctive treatment to medical and surgical therapy for treatment of active disease or for nutritional support. And it was really when it started to be used as nutritional support that it was demonstrated that it could actually help to induce disease remission. And this seemed to be particularly important in pediatric Crohn's disease. Avoiding steroids was of most importance, and it has become part of the standard care pathway in pediatric Crohn's. However, adults have always struggled with tolerance and palatability of using enteral nutrition. So I'm sure many of you might be aware that the mechanisms of how enteral nutrition actually works are still not fully understood. Initially, it was considered that nutrients being a major component of the luminal contents, perhaps that would have a role in the mechanistic process, and perhaps bowel rest and reduced antigenic loads were responsible. Maybe nutritional status, improving that nutritional status was another factor that was considered, but none of these have actually been proven to be the complete answer. In addition, supplementing with specific nutrients like glutamine or TGF-beta have also been postulated, and also looking at the fatty acid content. However, when you compare different types of fats within different feeds, there doesn't seem to be any difference in effectiveness. The change in the gut microbiota is what is certainly more of interest these days. I'm not going to go into detail of that on this session, though, but that's certainly an area that's of lots of interest. So looking at this Cochrane review from Narula, this was completed in 2018. There was an earlier version of this done in 2008. And then this was repeated. And where this was repeated, what they wanted to do was to look at the intention to treat analysis and also to look at the per protocol analysis to see whether there was any difference for enteral nutrition compared with steroids. So if we look at the pediatric studies at the top, there's two in this forest plot here, and you can see that it does actually favor the enteral nutrition, whereas for the adult studies, it favors the steroids. So on an intention to treat basis, it favors steroids for adults, and overall it favors steroids. If you look at it on a per protocol basis, you can see that the diamond is moving closer to the line, but it's not actually favoring enteral nutrition. So even when you look at just those patients who actually could tolerate enteral nutrition compared with steroids, it still doesn't appear to be more effective. And because of this, there are lots of reasons why this might be the case in adults. And we looked at asking dietitians across the UK what their experience was, and the side effects and reasons for earlier cessation were all related to things like nausea, diarrhea, headaches, dizziness, caffeine withdrawal, the unpalatability, compliance, the high volumes of formulas, and things like that that were really quite challenging. Other factors included hunger, abdominal bloating, and abdominal pain as well. And the other thing that's really important to think about is that we need to have joined up thinking when it comes to using exclusive enteral nutrition in these patients. And an MD team approach is absolutely vital. And since we've been using exclusive enteral nutrition in our patients, the whole MD team are completely behind it, promoting it all the time as part of the care pathway. And I'll explain that a little bit more when we come to the surgical pathway. So it needs to be considered as part of the primary or adjunctive treatment pathway. So as a primary treatment, it might be used to induce disease remission where steroids are contraindicated. Or it might be used as adjunctive treatment when you're bridging to another therapy to try and get that patient into a disease remission. We also need to think about how long we might be feeding someone for. Are we looking for a clinical response, or are we actually looking for mucosal healing? If we're just looking for a clinical response, then we might not actually be getting that mucosal healing, and mucosal healing takes a lot longer, so it's usually around 6 weeks or so. If we're thinking about using EEN, we need to make sure we're calculating requirements, using predictive equations and stress factors and physical activity levels. And we need to also think about the refeeding risk as well. So, we normally introduce enteral nutrition over a 3-day period for up to 10 days. Weaning off food and caffeine is a real challenge for adults. And when we wean down the caffeine, in our protocol at Guy's and St Thomas's, we do actually allow 1 cup of black tea or black coffee to remain in the diet while people are taking exclusive enteral nutrition. And this is to help prevent that terrible caffeine withdrawal and headaches. It's often used to manage the risk of obstruction in stricturing disease as well. And we need to be thinking about monitoring the side effects and the clinical response and nutritional status. In pediatrics, enteral nutrition is often given via a nasogastric tube, but in adults we find that they can manage it much better orally, and we give a variety of different products to try so that they can see which one they can tolerate the best. And it might be that they end up having several different types of enteral nutrition alongside each other. There doesn't seem to be a favoured enteral nutrition product in terms of the manufacturer when you do head-to-head studies, and in terms of the type of product, we use a whole protein product. There doesn't seem to be any better effectiveness from using a peptide or elemental feed. So from the BDA consensus guidelines, the statement that we have on exclusive enteral nutrition is to induce remission of inactive Crohn's disease. Exclusive enteral nutrition is less effective than corticosteroids. It may be used in mild to moderate disease where avoidance of corticosteroids is intended and dietetic expertise is available. That is absolutely crucial. We find that where we have dietetic expertise, we're providing support to patients on a weekly basis with phone calls during that 6-week period if the patients need it. And we need to be there in terms of getting the prescription sorted out in the early stages as well. And I'll talk a little bit more about how else we are sort of planning to help provide further support. In steroid refractory or steroid intolerant disease, exclusive enteral nutrition may be used as an adjuvant to induce disease remission in patients with active Crohn's disease, starting immunosuppressive or biologic therapy. And it may also be used as a primary or adjunctive therapy for a minimum of 6 weeks to induce disease remission and achieve mucosal healing in patients with mild to moderate disease in which corticosteroids are contraindicated or the patient chooses to avoid corticosteroids. So those 2 practice statements were also agreed. So the next part of this talk I want to talk to you about is my interest in surgery and Crohn's disease. Now we know that between 70 to 90% of patients with Crohn's disease will require surgery at some point during their disease. And patients with Crohn's disease are at increased risk of post-operative complications, wound dehiscence, etc. And they have suboptimal nutritional status. And because of the immunosuppression that they're on, they are at greater risk. So we don't know what the optimal nutrition in pre-surgical Crohn's disease is at the moment, but there has been quite a lot of work looking at using exclusive enteral nutrition. And when I talked about it earlier, I said that it was used in surgery in those 1970s studies. So it was actually something that was done quite a long time ago. We recently did a retrospective cohort study looking at using preoperative oral enteral nutritional optimization for Crohn's disease. On the left-hand side, you have all the sort of complications. And if you look at the rates of complications and the different groups, so the optimized group, we had 204 patients that were optimized on some kind of enteral nutrition. The orange group are those who were optimized on exclusive enteral nutrition, and the non-optimized group were the ones that did not receive any nutritional input, and they just were following a standard care pathway. So if you look at the surgical complications and the non-surgical complications and the infective complications, these are all significantly less in the optimized group than the non-optimized group. Unplanned stoma was similar across the three groups. This is using multivariate analysis, and the number of days in terms of the length of stay wasn't significantly different between the groups either. But this does go to show that, you know, there might be something in using enteral nutrition to help reduce those surgical complications. Another group from the UK looked at using exclusive enteral nutrition and showed that it provides an effective bridge to safer elective surgery for adults with Crohn's disease, and showed here that those who received exclusive enteral nutrition had far less complications in terms of anastomotic leak and wound dehiscence. And you can see here that this data is quite compelling. But we have to remember that this is, you know, cohort data. It's not high quality RCT data. And the research evidence in this pre-surgical area using EEN is particularly low quality, unfortunately. This review with this forest plot here suggests that nutrition support is favourable over standard care. And these studies included a selection of patients who received some sort of nutritional support, whether it was exclusive enteral nutrition or partial enteral and partial parenteral nutrition. So in terms of our BDA consensus guidelines, the statement says that there is limited evidence that pre-surgical exclusive enteral nutrition may reduce the length of post-surgical hospitalization in patients with Crohn's disease, and pre-surgical EEN may lower the risk of post-surgical infectious complications in patients with Crohn's disease. But this is based on retrospective case control studies. The ECHO perioperative dietary therapy and surgical position statement also suggests that EEN shows promise as a pre-op strategy, and the optimal duration and route of administration is best defined by the MD team. But high quality evidence is needed, and we are just about to start recruiting to a very large multi-center randomized controlled trial of using preoperative exclusive enteral nutrition versus standard care in patients with Crohn's disease needing surgery. This study has been funded by the National Institute for Health and Care Research and is called the OCEAN study. And we are going to evaluate whether 6 weeks of exclusive enteral nutrition helps to reduce the risk of complications and improves patient-reported outcomes 6 weeks postoperatively. So these are our joint primary outcomes. We are going to be recruiting patients from up to 40 different centres across the UK, because we need 618 patients to be randomised, with 309 in each group. So this is going to be an enormous study, over the next 4 years or so. And patients in the intervention arm will receive exclusive enteral nutrition for 6 weeks pre-surgically, and then all patients will be followed up for 12 months post-operatively with a variety of different outcomes. Because we're using this at different centres across the UK, some centres have very good dietetic input and other centres don't. So one of the things that we really want to ensure is that if there are centres that don't have the best dietetic expertise available, that we have developed a tool for patients to use. And we've developed this online patient resource as part of the intervention study, so that when patients get randomized to the EEN intervention, they will be given access to this patient resource. And within this resource, we have dietitians. This is myself and one of my colleagues, Dervla, where we're talking about the experience of using exclusive enteral nutrition. And there are various weeks that the patients will work through to help keep them motivated and help to keep them on track in terms of using exclusive enteral nutrition. So we also have patients who have provided their own experience of using exclusive enteral nutrition. And we have 3 patients who are sort of discussing their experiences throughout the 4 weeks of the course. And there are also some text reports as well from other patients who have experienced using exclusive enteral nutrition. And this is really to help guide those patients through the different difficult challenges. So, for example, during week 2, it's sort of maintaining the diet, overcoming challenges within those periods, and how to get up to speed, what to do with your prescription, how to make sure that you don't run out of your prescription, keeping motivated, and then the final 4 to 6 weeks preparing for surgery. So I'm just going to let you listen to this patient, Addie, who has given one of the reports.
I think the biggest change for me was, again, a couple of weeks in, was the reduction in pain and discomfort. I guess my Crohn's was at a point where, you know, I would always have loose motions or, you know, opening my bowels a few times a day more than I should be. But that was because of how far my disease had progressed. But what the liquid diet did was, and this was the biggest, you know, savior for me on the liquid diet, was the pain management. I'd gone from, you know, literally being on my knees in pain at times to actually being able to get by a normal day.
So that's his description. So there's lots of these short videos throughout the whole program, and there's also opportunities for patients who are taking part in the intervention to actually add some comments themselves to help improve sort of the peer support that patients often find is missing in this kind of treatment pathway. What we also find at our centre at Guy's and St Thomas's is that we have this very strong multidisciplinary team approach to delivering exclusive enteral nutrition. And when patients go to see the surgeons, the first thing that they say as part of their surgical pre-optimization, they will be seeing the dietitian, and the dietitian will give them information on how to use this liquid diet, because it is something that they feel very strongly about. Is going to help improve their outcome after surgery. So having this really important approach from the whole of the MD team, from the gastroenterologists to the colorectal surgeons and the dietitians, all saying the same thing and supporting the patient throughout the EEN intervention. We're hoping that by doing this big study across the UK, we're actually going to be able to see whether or not exclusive enteral nutrition actually is the way forward for pre-op optimization of surgical Crohn's disease. Another area that has been of great interest to me is sort of the food and nutrition problems that bother patients with inflammatory bowel disease. And quite a few years ago now, we did an initial survey of patients in clinic who gave us some indication of how nutrition and food has impacted their social activities. So going out, the real challenges that they have going to work, eating out, using public toilets, relationships, appearance. And on the back of this, we developed the food-related quality of life tool, which has been validated for use in IBD. This is a questionnaire of 29 questions with 5 different themes within it, looking at personal experience of relationships between IBD and food, managing diet to control IBD and its symptoms, the impact of food-related issues on everyday life, acceptance and normalization of food and its impact in IBD, and sources of information and support, and how patients actually feel about food-related quality of life, because it's such an important area that is often not addressed as well as it could be. We did a very large survey in 1,221 patients that got published in the American Journal of Clinical Nutrition, and it showed that the food-related quality of life in IBD is highly prevalent, and it's associated with recurrent disease flare-ups, reduced IBD-specific quality of life, and lower key nutrient intakes related to gut health and bone health. And we find that we now use the food-related quality of life tool in clinical practice, and I'm hoping that within the next year or so, I'm going to have enough data looking at those patients who have been through the exclusive enteral nutrition pathway, seeing what effect that has actually had on their food-related quality of life. So the last area I wanted to talk about today is functional bowel symptoms in inflammatory bowel disease. These are extremely common in IBD, and many patients alter their diet to control their symptoms. And the treatment strategies that we use for managing functional bowel symptoms in IBD are very similar to those that we might use in the management of IBS. Functional bowel symptoms are highly prevalent in IBD, affecting approximately sort of 39 to 40% if you combine all this data together. So it's a real issue. If you compare it to the prevalence of IBS in the general population, it's somewhere around 5% using the current RAIN4 criteria. The problem with functional gut symptoms and IBD is sometimes it's really hard to differentiate between what's actually functional bowel symptoms and what's actually IBD, what's active IBD. So there are some things to be thinking about. So ensuring that fecal calprotectin is less than 150. Has there been some recent endoscopy or imaging indicating that there's no active disease within the gut? Do you need to consider other differential diagnosis, things like bile salt malabsorption, or is there any structural complication? And being really, really clear that IBS and IBD symptoms are so alike, it's important that we do measure these things and make sure that when we're treating the functional symptoms in IBD, that patient hasn't also got moderate or severe active IBD. So the most favoured diet in the management of these symptoms is the low FODMAP diet, and there's quite a lot of evidence now that has been accumulating on this from initially retrospective uncontrolled studies and then also some randomized controlled trials. And we did a randomized controlled trial a few years ago, this one down at the bottom by Cox, where we looked at a low FODMAP diet versus a sham diet or a placebo diet for 4 weeks. And we found that 52% of patients on the low FODMAP diet were reporting adequate relief versus 16% who followed the sham diet. The other two RCTs also showed that there were significantly lower symptoms on the low FODMAP diet, this one versus a typical Australian diet, and this one versus a habitual diet. In terms of our work, we also looked at the IBS symptom severity scoring system and found that actually, although it was approaching significance, it wasn't actually different between the low FODMAP diet and the sham diet when you grouped all patients together. However, when you looked at ulcerative colitis patients and Crohn's disease separately, we found that the IBS SSS was significantly different for ulcerative colitis, but not for Crohn's disease. And we found the same thing for the IBD control as well, that it was significantly different in the ulcerative colitis group, but not the Crohn's disease group. In terms of dietary intake, the low FODMAP diet is something that we need to be really careful of, because nutrients do drop down in the low FODMAP diet compared to other dietary treatments. And when we compared it to a sham diet in this particular study, there were significantly lower energy, protein, fat, and calcium intakes in the patients following the low FODMAP diet. So as soon as that initial 4-week period is over, it's absolutely vital that patients are instructed on the FODMAP reintroduction process. Another reason to reintroduce is the concern over the low FODMAP diet on the microbiota. So we know that in IBD, there's reduced diversity, reduced spermacutes, particularly F. prausnitzii, and there's increased enterobacteriaceae. What effect would a low FODMAP diet actually have to the microbiota, and also perhaps on inflammation? So we looked at this as part of our study, and this is the data from Selena Cox. We had no impact on the between the two diets for fecal calprotectin or for CRP levels. And in terms of the microbiota, we did find that some of the bifidobacteria were reduced after the 4 weeks of the low FODMAP diet compared to the sham diet, and again for some of the F. prausnitzii as well. So it's really important that we go through that reintroduction process. So in terms of FODMAPs and IBD, it's a complex diet for functional gut symptoms. It's not a treatment for moderate to severe IBD. It might be helpful in Crohn's disease or ulcerative colitis in remission if functional symptoms are present. The diet does reduce bifidobacteria and F. prau in IBD, and the differences in dietary intake are definitely something that we need to be aware of. And it's really important to ensure that adequate nutrient intake is followed, and that the diet is always delivered by a dietitian in inflammatory bowel disease. So in terms of the BDA consensus guidelines, the statement says that a low FODMAP diet may improve global functional bowel symptoms in quiescent or mildly active inflammatory bowel disease. And the practice statement is that dietitian-led low FODMAP education in IBD may be useful for persistent bowel symptoms in the absence of inflammation. And it involves short-term FODMAP restriction, FODMAP reintroduction to tolerance, and personalization for long-term management. Okay. So in summary, I'd just like to say that I've taken you through lots of different areas that I'm particularly interested in: diet and nutrition in inflammatory bowel disease, looking at the high prevalence of undernutrition in IBD and how we look at that in terms of guidelines, in terms of nutritional assessment, and how important that is, particularly in a longitudinal setting. The role for exclusive enteral nutrition as primary and adjunctive treatment in IBD, and then thinking about the pre-surgical nutritional optimization. I think this is a really exciting area, and I hope that our big randomized controlled trial in the UK is going to give us some answers in the future. And maybe our online resource will actually help to standardize the care that we hope that patients will receive, and mean that they're actually getting good information about using exclusive enteral nutrition, and will be able to follow that kind of restrictive liquid diet. Also, food-related issues are a major concern for patients, and measuring food-related quality of life should be part of our standard IB care pathway, perhaps, and it might be something that we can monitor and improve over the disease course as well. And functional symptoms in IBD are common, and dietary management may be helpful. So I'd like to say thank you very much for inviting me to talk today. I'd just like to acknowledge all the different teams that I work with, some of my research colleagues, so Professor Jeremy Sanderson, Kevin Whelan and Peter Irving, Dr. Hadi Steidecker, Irina Dimody, Catherine Wall, Bridget Wilson, and Beatrice Stonehow, and the gastroenterology specialist group of the BDA, and then the dietetic and gastroenterology teams at King's College London here, and my clinical team at Guy's and St Thomas's as well. So thank you very much.
We can open it up to questions, or I have a few questions. You can go ahead, Shazad.
Okay, thank you. Dr. Lomer, thank you for speaking and accepting our invitation. It was really wonderful. A really comprehensive overview of nutrition and IBD. My question is, I have two, actually. The first one is, what about post-acute flare of disease once the patient leaves the hospital? And do they sustain some sort of oral and enteral feeding as part of their sort of maintenance regimen? And those patients that do sort of use this on an outpatient basis, what level of strictness do they have to adhere to that requires this to actually be effective? Thank you.
It's a really interesting question, because we try to encourage patients to follow the diet exclusively. So, up to sort of 100%, but we appreciate that most patients are somewhere between 75 to 100%. As part of our trial that we're going to be running, we're going to be looking at compliance and measuring that from a central dietitian. So really trying to understand what's going on and whether we can relate that to, how that might impact on the surgical and nutritional outcomes of patients. In clinical practice, we may find that patients are following the diet 75% of the time, and for the other 25%, they might be having some additional normal food. We try not to bring patients into hospital to get them started on enteral nutrition, so a lot of it is done as an outpatient anyway. It's only if they're really struggling and they need to come in and have a nasogastric tube, which really doesn't happen very often. If they do come into hospital, often it's because they're just not tolerating enteral nutrition at all. Maybe they have obstructive symptoms and they need parenteral nutrition to help them as well. But we would try to be giving some enteral nutrition at the same time as the parenteral nutrition. Hopefully I've answered your question as clearly as possible. It's a team approach, and I think, in reality, there are a lot of new diets that are now coming forward in the management of Crohn's disease in particular. And if you know of the work that's coming out of Israel, where they're using partial enteral nutrition, so 50% enteral nutrition, and the CDED diet, the Crohn's disease exclusion diet, this is particularly useful, and they've been using it in pediatrics, and they've done some work in adults now as well. So this might be a way forward so that people don't have to follow a completely exclusive enteral nutrition diet. There's also the group from Glasgow who are looking at the CD treat diet for Crohn's disease. And, I'm sure you're aware of the specific carbohydrate diet and how that's being compared to the Mediterranean diet. there are lots of other food treatments that are being considered. We don't feel that they're quite there yet, but there is a lot of interest. And my colleagues at King's College London's, led by Kevin Whelan, they're actually looking at reducing additives as well, and hopefully their study will be finished next year. So that will be really exciting to see what effect that's having to help induce disease remission. So, in some respects, we may be moving away from exclusive enteral nutrition in the longer term, but in the pre-surgical setting, it certainly is of much interest and may be actually helping with some of the surgical outcomes.
Thank you.
I have a question somewhat related to that as well. So what I understood was that it would take 6 weeks of exclusive enteral nutrition to introduce mucosal healing. But was there a time frame associated with like how long we need to work optimizing nutrition before surgery?
So we've gone for 6 weeks because we believe that a minimum of 4 weeks is what you really need to be aiming for to get that mucosal healing. And if patients are on other treatments, so if, for example, you're having to wean them off steroids before surgery, that enteral nutrition will actually help with that process as well while you're weaning them down. So that sort of 6 week window is what we're really trying to go for, so that you can get the enteral nutrition fully established within a week or two, because once you randomize someone to a study and they're having surgery in 6 weeks, you need to make sure that you can actually get them into that treatment pathway and get them established on the enteral nutrition. So the 6 weeks is what we've gone for to ensure that we get a really good, at least 4 weeks of enteral nutrition. It's a really hard thing to say. What is the ideal, time period? And we also appreciate that surgery can be delayed as well. So we say that patients can continue on the enteral nutrition for up to 12 weeks. And if they go beyond that, it's really up to the patient, because this is quite a pragmatic trial that we're having. It's really up to the patient how much enteral nutrition they want to continue with beyond that time. And, it may be that they're very keen to continue it. And you would hope that their surgery isn't being delayed beyond 12 weeks. I'm not sure what happens with you, but, cancer seems to trump Crohn's disease surgery quite often in the sort of the waiting lists. So, if there's a new cancer case, then, it can be quite a challenge. But I think, when patients are being given a very specific dietary treatment as part of their pathway, they really need to be prioritized, because these are patients who are high risk. They're at risk of costing an awful lot more to the healthcare system if they're not managed appropriately.
Thank you. Okay, if there are no more questions, I think we can thank you for your time again. If no one has done the math, it's actually 9:30, 10 o'clock there now. So.
Oh, thank you so much.
Oh, that's a pleasure. No, it's really nice. And, it's lovely that I've been invited to speak to you, and I hope you found it helpful.
Thank you.